Let's talk about irritable bowel syndrome. As the name implies, bowel is irritable. There is no such inflammation or anything malignant, but it is just irritable. It means there is maybe some functional abnormality inside the small intestine. In clinical practice, we use Rome-4 criteria to define irritable bowel syndrome, which tells that patients should have recurrent abdominal pain at least 1 day per week in the last 3 months. At least 1 day per week in the last 3 months, and that abdominal pain should be related to the defecation. It should either relieve with defecation or aggravate with defecation. And it should be associated with change in frequency of stooling or associated with change in appearance, form of stool. So at least 1 day per week in the last 3 months associated with related to defecation or associated with either change in form of stool or consistency of stool. So if any two of this is present with abdominal pain, then we call it irritable bowel syndrome. And while we diagnose irritable bowel syndrome, we should be cautious, because there are many mimickers of IBS like inflammatory bowel disease, maybe colorectal carcinoma. So to rule those out, we screen for certain alarm features, like patient is whether elderly or patient has weight loss or GI bleeding, occult GI bleeding, or any mass in the abdomen, or if there is family history of colon cancer or inflammatory bowel disease, or patient has to wake up in the middle of the night to go to toilet multiple times, so whether there are nocturnal symptoms or not. So if these are present, it signifies that there can be some pathology rather than just only IBS. And talking about pathophysiology, how this condition undergoes its process inside the body, there are many theories, hypotheses. Some tell that there are behavioral and psychosocial factors, because they relate that patients have also associated psychiatric illness like anxiety, depression, panic attacks. And there are also some physiological factors like related to dysfunction of the 5-HT3 receptor. So we utilize 5-HT3 receptor either agonist or antagonist to treat IBS, depending upon whether patient has constipation or diarrhea. And they also tell that there is brain-gut interaction with they call it brain-gut axis. So this bowel influences the bowel, means the probiotics, whatever the flora inside the bowel, this also influences the brain. And variety of luminal factors like a small intestinal bacterial overgrowth. So these also are incriminated or related to IBS. And obviously nowadays the popular, they call it, take low FODMAP diet, low fermentable oligosaccharide, disaccharide, monosaccharides and polyols. So definitely there may be some pathophysiology related to FODMAP diets. Now talking about clinical features, so patient may have either constipation or maybe diarrhea, or alternating constipation or diarrhea. In addition to these constipation and diarrhea, patient may have migraine, dyspareunia, interstitial cystitis, other psychiatric comorbidities as well. And what investigations do you order in IBS? So definitely we have to rule out the mimickers like inflammatory bowel disease. To rule out inflammation, we do CRP, fecal calprotectin. And to screen for parasitic disease, we do a stool REME, look for ova, parasites, stool culture sensitivity. You have to rule out celiac disease, lactose intolerance, bile acid diarrhea, and thyrotoxicosis also causes diarrhea. So we have to rule those out. Talking about management, how do you manage our patients with IBS? So we do symptomatic management. The first of all, you have to reassure the patient and address the symptoms. If there is diarrhea, then we advise for low FODMAP diet and try for gluten-free diet. And if patient has severe diarrhea, then we also prescribe anti-diarrheal agent like loperamide or codeine, cholestyramine. And if not responding to those, then we go for amitriptyline, imipramiine, Rifaximin. And if patient has constipation, then we advise for high fiber diet, especially soluble fiber rather than insoluble fiber diet. And we can go for isapghula, psyllium, Prucalopride, Linaclotide. These activates the chloride channel inside the gut, and there is secretion of the H2O, water inside the gut, that relieves constipation. And despite that, if symptom persist, then we can prescribe duloxetine, relaxation therapy, biofeedback. And to address the pain, bloating that patient may complain, we advise for low FODMAP diet, exclude gluten, dairy product. So we can try those. And if despite that, if symptom persist, pain, bloating, then we can prescribe spasmolytic drugs. Like there are various spasmolytic drugs, hyoscine, mebeverine, and also peppermint oil. And we can try Rifaximin and amitriptyline, imipramiine. So this is in nutshell about irritable bowel syndrome, and I hope it was helpful you to understand what is IBS. And if you have any questions or concerns, you can comment it down and we will be happy to answer it. Thank you.